Jodie Austin. I'm the Clinical Informatics Director for the Smart Hub, which is an operational team which sits embedded within the overarching QDEC. I'll be presenting today with Reggie Phillip, who's the Data Manager for within the Smart Hub as well. I would like to acknowledge the traditional owners and the custodianships of the land on which we're meeting today. So I thought I'd just take you back to before we were the Smart Hub, we were actually the Smart Project. So that was back in where you saw that Christmas party photo that Claire showed in 2021. That was us then as the Smart Project. And so that was where Claire and the team had won it was a $3 million UQ strategic funding bid to develop this, spend a year trying to develop, I guess, a team that could streamline access to healthcare data for our researchers. So at the moment, there has been so much emphasis up until now with getting these large electronic medical record systems up and running and implemented into our healthcare systems that there was not a lot of focus up until that point in trying to help extract data to use it for research purposes. So that was really, I guess, where the premise of the Smart Project came along. And the idea was that we could try and get a dedicated team to be helping to promote that idea of a learning healthcare system where the data that was being generated through routine care, we could research on that, understand, learn the findings, and then put them back into care. So that was the premise. So we spent, it was a little bit more than a year, I think, on the Smart Project. And then the idea was to transition into a BAU model back at the beginning of this year. So we've been transitioning, I guess, but there's been a bit of a delay in terms of us transitioning into a true BAU model because we were really working towards our team being embedded across both the University of Queensland and Queensland Health, which is where we're really, really close, and it's really lovely to see our colleagues from eHealth Queensland here today who we're hoping to work alongside to make this really work and operate. So that's the idea. I'm not going to say we just use the term smart because it's a very long-winded term otherwise. But the idea of smart is that we had this goal to try and bring the university sector together, who are heavily focused on research, and bring that together with the hospitals and health services who are there providing the care at the front line, who are generating, huge amounts of data now with the electronic medical record that's rolled out across the state in Queensland Health. And can we bring the two together so that they can work together collaboratively with that focus on trying to really promote a learning healthcare system? So our team within the Smart Hub, at the moment, is myself as the Clinical Informatics Director and Reggie as the Data Manager. We've also got Joe, who's a BI developer. We have Josh, who is with us part-time as a clinical informatician. And we've also got a new clinical informatician who'll be joining us full-time early next year. So this is the overarching research ecosystem of QDEC, and I thought it might be easy if I put this up so you can understand where the Smart Hub fits in to the greater QDEC concept. So the Smart Hub is kind of sitting across two of these areas within the ecosystem. So in terms of the access, so what we're really trying to set up is that operational layer that can help researchers, whether they're university-based or whether they're clinicians from within the healthcare sector, whether we can support them with accessing the data that they need for their research, and then also trying to help with the data and how they're managing to access that data. And Reggie will talk to some of the novel approaches we're working on there within the data itself. So as I say, what we do is really trying to create and maintain that research data infrastructure to support digital health research. And how we're doing it is in two ways. So we're trying to streamline and make it safe and efficient to access that healthcare data. So we've got a team that's purely dedicated to research requests. So we're not looking at operational activities, we're really focused on research. And then supporting some of these novel methods that QDEC are looking at for healthcare data access. So this is just to give you a bit of an idea of this, and this is a concept that's coming from the broader QDEC community, not just the Smart Hub, but trying to look at the approach to data in this tiered approach where you're still going to have those that need for accessing, identifiable EMR data, for example, at the top of that pyramid. But are there other novel methods that can be, going on in the background to try and streamline access that might mitigate some of the needs for, there's a very long, convoluted, ethics and governance process to access that top tier of data. So I'll talk to that top tier and how the Smart Hub's going to I guess, facilitate access to the EMR data. And then Reggie's going to spend a bit of time talking on the bottom two layers, which is the common data models and synthetic data. So the idea is that we will facilitate research requests, and as I said, it's for any researchers that are coming internal to Queensland Health or external from the university sector. So we spent a lot of time during that SMART project establishing standard operating procedures, which we're now working on fine-tuning with eHealth Queensland to make sure that they're robust from both sides. But we did have a lot of, we had a working party set up while we were setting up those standard operating procedures to make sure that they were correct from both organisations. And then ensuring, obviously, working to get that data, making sure that it's done so in an appropriate way, it's transferred in a safe way, for example. And we also have, as I say, I showed you the team before, we have a few clinical informaticians on the team. And so they've been, as part of this process, what they were doing is meeting up with the researchers and getting to understand what the research project was that they were interested in undertaking. And then we really needed to make the call whether, first of all, was it in our scope? So was it a research request? And the way we were really, I guess, delineating there was, have you been and got an ethics approval? So it could still be an ethics exemption, but they still needed to have that project. It wasn't just a purely operational BAU where there was no HREC involved. And there was a lot of, the researchers that were coming to us were from really two different camps. There were the ones that were, I guess, working internally within Queensland Health, so they have a really good handle on what data you can get out of the IEMR. And then you've got the researchers that are coming to us that are external, and they've heard about the IEMR, they kind of know what they want, but they have no idea what's in there. And so they needed a lot of help in terms of trying to show them what kind of data might be potentially useful for them with their research. There were a few projects in that SMART project phase too, where we actually, by the end of the process, we worked out that the IEMR wasn't really the best data asset for them. So, for example, we had a project where they were really looking, they were focused on maternity data, and what they were after was really better from the perinatal data collection. So we sent them over to the Statistical Services branch for that data. And similarly, projects where they're trying to define their scope, looking at diagnoses, which is fairly poorly documented within the IEMR. So in those instances, again, we were sending them across to the Statistical Services branch to capture that data for their cohort. And so these are the standard operating procedures that we worked through as part of that first 12 months or so on the SMART project. And it was really trying to map out, because it is such a long, convoluted process, to get your ethics and governance in place through Queensland Health. And I think if you talk to any of the PhD students in the room here today, they'll have all had their war stories that they can share with you on that process. So we tried to really map that out and make it as clear as possible so that it was easier for the people that were coming through behind us on what, and it doesn't make it any easier. I think it's still a very long process, but it makes it easier in the sense that you understand what steps come next. And we also created some standard operating procedures as well for the technical sides of the data extraction piece, which Reggie will be working on. And so I thought maybe just before I hand over to Reggie, I'll just give you a few examples of, at that top tier of that pyramid, some of the data extraction requests that we've received so far with the Smart Hub. So the first is Judas, which is the deteriorating early warning tool. So this was a consultancy project where the Queensland Patient Safety and Quality Improvement Service have come to QDEC and asked if we could collaborate with them. And what they're trying to look at here is, I guess, really understanding what are the current issues with the DUTE system that's currently at play within the digital hospital systems across the state. And so it was a two-piece, it was, I guess, mixed methods. So we were doing a qualitative component where we were running focus groups with the clinicians pre and post upgrade of the DUTE system. And then we're going to do a quantitative component where we would use the Smart Hub for data extraction to look at usage statistics pre and post. Empower, so I just wanted to, I guess, throw this one out as an example, because what we're looking at here, and this is not statewide data, this is just Metro South, but looking to compare, so for example, if you're running a clinical trial and you're trying to recruit your participants, how effective is it if we just run the traditional manual recruitment process versus can we pull structured data from the IEMR to find our candidates, or can we screen the unstructured data? So we've got 3 arms running in that project to see which is the most effective for trying to find our clinical trial participants. And then this one is an example, and I don't know if Andrew Burton-Jones is in the room, but this is just for his... Is he here? No. This project's been going on for a long time. It's been stuck in a lot of governance issues, but we're getting really close to the end now where I think we can get to the point of actually extracting the data, but it's been a long process. But the premise behind this project is that we're looking to see whether we've had any clinical variation in the treatment to patients, depending on whether they've been treated using power plans from within the IEMR versus not using the power plans. And so I wanted to give this as an example because we were working really closely with the Statistical Services branch on this because this is a data linkage project. So what we're trying to do here is pull data out of the IEMR, but we want to look at, for those patients, and we're specifically looking at diabetes ketoacidosis here for this power plan, but we want to then look at readmission rates, we want to look at 30-day mortalities, for example, and so we need to link that data with the Statistical Services branch. So that's a pretty cool project in the sense that we're trying to work across, and we're really trying to forge new ways of doing that with working with SSB. And then lastly, before I hand over to Reggie, this is being run by a haematology registrar from Queensland Health, and so they want to look at doing some machine learning to predict febrile neutropenia. And so we're really quite close now to the tail end of all the governance approvals coming through, and the Smart Hub will help with the data extraction before they start running their machine learning algorithms. And so that's an example, as I was saying, from that pyramid approach, the top tier there with accessing EMR data, but there are a lot of other projects that are going on that I guess are a little bit more consistent, that Reggie's had a lot to do with over the past 1 to 2 years, trying to create those novel methods that are going to support researchers with accessing health data. So whilst we're in this, I guess, limbo in terms of being able to access the actual production data, we've been doing a lot of work on the proof of concepts for these 2 projects. So I'll get Reggie to explain those in detail to you. Thank you.
While sitting there, I was thinking, preparing that whole IMR Queensland health data mapping into OMOP is easier than sitting there waiting for and explaining it. Sorry. I might not be good at explaining. So these are the 2 projects I have been leading at QDAC for the last 2 years. First one is OMOP. OMOP stands for Observational Medical Outcomes Partnership, which is an international gold standard to transform and standardize data. So when we transform and standardize this data into OMOP, Common Data Model, researchers and health professionals can use that data to understand patients' health, and then they can use that for research studies. OMOP uses Common Data Model, which can develop standardized vocabularies to ensure research methods can be systematically applied, producing comparable and reproducible results across organizations. OMOP is not a new framework. It's been around more than a decade, and mapping IMR or EMR data into OMOP started around in 2008. It's been used more than in 41 different countries, and 12% of the population been mapped into OMOP. There are many OMOP terminologies used in OMOP, and these are the SNOMED code, Ionic, and RxNOMA methodology we have used when mapping our Queensland Health IMR data into OMOP. SNOMED code is mainly used for conditions, procedures, and observations. And in IMR, it's already all the data sets are mapped into SNOMED code, so which was easy for us to map it. Ionic and RxNOM, we have used our medical student support or help to map that data. There are many tool sets available with OMOP. ODC ecosystem, ODC develop and promotes quite a lot of open source tools and methodologies for helping with the research studies. So Atlas is one of the front-end tool which we can use with OMOP database. Atlas is for executing cohort studies. Data validation dashboard and Themis can be used for data quality assessment in OMOP. Achilles is the one we used for database characterization. And the structured and standardized nature of OMOP data, it's make it very valuable in research, conducting observational research and generating insight studies. This is the OMOP common data model. In this one, as you can see, it's a person-centric model. So each person or patient has got a unique identifier in this model. And all the other events like visit occurrence, measurements, procedure occurrences, devices exposed to a patient, all these events are recorded as records in the system. And timing of each event happened is also recorded in that model. So yeah, this is how it looks once we map the data into OMOP model. OMOP CDM is designed for longitudinal data analysis. So once we map the data, as you can see, it's every person has got, in events is called concepts in OMOP. So each person will have many concepts attached, and then for each concept there will be a date and time attached. The concept could be measurements, drugs, procedures, and goes like that. And this is one of the snippets from Atlas dashboard. And Atlas is a very good front-end tool to use with OMOP. At one installation of Atlas, we can map it, connect to different versions or different database instances. And so if you have different use cases to work on, in Atlas itself, we can just check it with the development version and then run the same thing in production version and see the difference, or make sure, okay, that the study is good. And also, you can download the script from one Atlas version and give to another set of people who has got Atlas installed, and they can just import that script and run it in their instance. And future, what I say is OMOP can be used in federated learning. So we don't have to share the data. We can keep the data at their instance itself, and then institutions and parties can work together in developing machine learning models and then share that script or the final output each other. And OMOP also is a good one for patient-centric research purposes. So incorporate patient-reported outcomes, preferences, and experiences into research studies. We at QDAC, we also prepared an implementation guide, how to implement OMOP and Atlas. It's not an easy task, even though it's open source, but sometimes a small mistake will be enough. For last 4 days, I was working with Western Health to get Atlas working. So so this implementation guide, I hope I can finish it with the Western Health project. The next project we have been working on is the synthetic data. Synthetic data, I have worked with Queensland Health for more than 17 years, so I never had to use any synthetic data, maybe a couple of records or for testing an application. But when I moved with Claire, she was like, oh, if you can't get access to production data, let's get synthetic data. I was like, okay, something different, something challenging, let me try. Okay, so we started with the synthetic data. Yeah, it's a good one to work on, and it has got a lot of, it's really good to work on. And for me, anyway, I am a data person, so I was like, okay, sometimes even Claire says, so 1,000 records is enough. For me, 1,000 is nothing, so I prepare 100,000, and here, Claire, I have got 100,000 records, so it was good to work with. And synthetic data set we prepare at QDAC is semi-representative data set. So semi-representative is we don't have access to the production data. So we use all the publicly available sources to prepare the data set. So we use all that to prepare the models, and that model used for generating synthetic data. And for synthetic data generation, we were using Cerner data schema. We are familiar, I'm very familiar to Cerner data schema, so I started using that. We downloaded that schema from internet, and then using C# and SQL programming to prepare the data set. And that data set we also mapped to OMOP. So OMOP, it's a common data model also we are using. So we have got database with the synthetic data. The project we did is IMR trained domain data we used. That's also there. So we have got multiple synthetic. It's okay. Okay, synthetic data, the project purpose is mainly for data. We get a lot of requests for data extracts, generating dashboards, or we also be preparing some data sets for training machine learning models. So that's a major purpose of that. Even though it's a synthetic data, we still do the data validation, make sure the data is accurate and good enough for researchers to use for their studies. And some of the use cases we have done is Mason project, which look for CKD development, and then a difference project, which for difference project we actually used Cynthia. Cynthia is another open source for generating synthetic data, so we use that one to generate synthetic data for difference project. And the current project we are working on is Nina, which look for a lot of different diagnosis like diabetes, osteoarthritis, cancer, and rheumatoid arthritis. And one of the example use case we developed using synthetic data is the healthy weight dashboard, which currently we finished that project in the beginning of this year and handed over to Okio team, and they are looking at putting that into production. We also have an inventory with, for synthetic data, and each record will come up with that. Yeah, it's a fake data that's not useful for clinical use. And this is the progress of our all our projects. We started our journey in synthetic data June 2022, and we finished a couple of projects. And the Nina project we are expecting to finish in end of January, generation of synthetic data. That's all I have. Oh, yeah, one more. Synthetic data governance. We are currently preparing a standard operating procedure, which is in draft form for synthetic data. Thank you.
Well, thanks, Reggie. You did a really good job of helping explain that, and you made it sound so simple. I don't know how you do it, but we've got about 5 minutes left for some questions. If anybody has some questions for Jody or Reggie, or any of the for anyone that's presented since morning tea. Yes.
I can just yell if you like. Oh, all right.
Here you go. Save your voice.
Thank you. Thank you for those insights, and it's very fascinating. Ross from eHealth. My question, I've got two. One is, has there been any analysis done on the synthetic data versus production data and running models through to confirm that?
Okay.
No? Okay, that's all right. Is that coming? And I have one more. If that's all right.
Oh, we didn't know if we were doing that, that's all.
Oh, sorry. So that, yeah. So no, they haven't. And
Can I just add to that though, that that's what we're aiming to. So that's what we, I guess, put forward. Okay. Thank you. Oh, okay. You're just here, but I'll talk to you with the microphone. So that's what we're aiming for, and so that's where, hopefully with us, Reggie and I being conjoint positions with eHealth Queensland, the two proposals that we've put forward, one being representative synthetic data, which would be what you're talking about, where we look to marry the statistical properties of what's out there in production.
cool. And one more question. And the other question is in relation to the Oracle Health, so the IMR database, and mapping that to standards. Are you using a set standard base such as FHIR or HL7, or what are the standards you're using, and can they be leveraged across the rest of the system?
I haven't been using Fire or anything. Yeah, Fire is a good one to use, but the projects currently I have done is using IMR trained data. I haven't used anything. I have just used the Cerner command language, CCL, to extract the data because we haven't had direct access to that. So then SQL scripts to map the data into OMOP. There is Rabbit and White Rabbit and Rabbit in a Hat you can use for mapping the data, but I haven't used that. But for Western Health also, I already had all the scripts, so I directly use that for Western Health.
We've got one. Oh, you've got a question. One more question. Thanks, Colleen.
Just one question in case we had more consumers in the room. I would just say they might be thinking around when we're talking about all their data and we're talking about federated learning and synthetic data, how will their privacy be potentially protected as we pass on information to our research colleagues? I think that might be something people would be interested. So happy for you to repeat the question.
So I think what you're saying, Colleen, is how do we make sure that consumers are feeling comfortable with these novel approaches that we're taking, so that the data is going to be done in a ethically and morally appropriate way? So the idea with synthetic data is that it is synthetically generated, so therefore we mitigate those disclosure risks of the actual patient data being, sent out there across to researchers with the option for them to actually be or potentially be re-identified. So I guess synthetic data is really being driven to try and mitigate those risks of disclosure of the patient. So that's, I guess, from the synthetic data side of things. And I think also from the OMOP, the Common Data Model point of view as well, again, that is something that is offering the data, but offering it in an anonymised way. But that was kind of, the OMOP was what was in the back of my head when I was asking Craig that question this morning. When we do go to look at moving something like OMOP into production data, how do we, because it is quite a technical project, how we get consumers involved in something like that, I think we're yet to understand.